Good afternoon. Thanks for the kind introduction. I would like to present today a predictable protocol for extraction and immediate implant placement that I have been performing for a year and a half now and has given me very nice results. I would like to share it with you and explain the biology that supports the idea. Today, preserving the ridge has become a must in implant dentistry, and many techniques have been published with a very predictable results, either at Pontic sites or for implant site development, such as root submergence technique, where we submerge the roots in order to preserve the volumes of the ridge, preserving the bundle bone around their teeth, the socket shield, where we actually preserve the buccal plate, buccal part of the tooth, in order to preserve the buccal plate, or the classical socket preservation with bone graft material. But what happens after dental extraction? What happens with all that cementum on the root surface responsible for the tooth attachment? And those Sharpie fibers that were cut off, that compact and hard bundle bone and the rest of the periodontal tissues? Well, basically, when we extract the tooth, everything turns into nothing. Shrup in 2003 published an article about the events that occur after dental extraction, and he showed that after 12 months of a tooth extraction on molar and premolar areas, they lost more bone in width than in height. The mean average of bone loss was 5 to 7 millimeters, and that the 2/3 of this bone loss occurred within these first 3 months, and that the width of the alveolar ridge was reduced by 50% during the observation period. So extracting a tooth and do nothing is the worst thing we can do, because thanks to that tooth, that cementum, that PDL, that panda bone, that bone, we still have volume. Looking at this 3D interpretation out of a CBCT, we can observe the preservation of the bone even under non-healthy periodontal conditions of that tooth compared to the severe atrophic edentulous areas. But which is the biologic pattern of bone loss? Araujo and Lind in 2005 showed in a dog study that after 8 weeks of a tooth extraction, there was a huge osteoclastic activity, especially on the buccal wall, which caused a more pronounced bone loss than in the lingual wall. So socket preservation was considered the best and more predictable treatment option in order to avoid that buccal lingual collapse after those studies. Antonio Baroni in 2008 compared socket preservation with xenograft and extraction alone, and the results didn't show a zero collapse in the socket preservation group, but a significant difference with the extraction alone group. So, what do I use to preserve the bone? I need a biomaterial that covers all my expectations in terms of turnover. I need a bone graft that has a quick transformation into vital bone. Space maintenance at long term or preservation of the original volume. Management, a graft with good management and stability once it's placed. And of course, not too expensive. Today we have many different types of bone grafts available: xenograft, allograft, synthetic bone, growth factors, or even the combination of them. We wanted to know which one of those materials has the best behaviors in terms of bone regeneration and maintaining the ridge, avoiding its collapse. Another study that compares xenograft and synthetic bone on incisors, canines, and premolars areas using biols and bone ceramic, covered by BioGuide, showed these results. The biols group lost 2.1 millimeters of bone, and the synthetic group lost just 1.1. Those results with xenograft are pretty similar to the ones published by Antonio Barone. So as I always say when I speak about growth factors, life is movement. We work on a dynamic world full of cells ready to move, and we have to promote that movement. Growth factors therapy has been proven by many articles to have a positive effect in wound healing process, as well as soft and hard tissue regeneration. This is a biological process, and we must think biologically. We must be biologically driven. This article, and many others from Eduardo Anitua, Robert Marks, Joseph Chokroun, compares the use of the fraction 2 of growth factor, the richest part, in fresh extraction sockets versus not extraction alone, and the results are significantly different. Clinically, a significant difference was observed in terms of volume changes in areas treated with PRGF. Radiographically, the ridge was preserved, looking at the CBCT as well as the soft tissue quality in terms of keratinized tissue and more mineralized bone at the sites treated with growth factors. So socket preservation with different bone materials after those studies became the best and more predictable treatment option in posterior areas where the fresh extraction socket would leave a big space and a reduced amount of bone to place an implant. In 2013, Markus Hurseler and his team developed a pre-extractive interradicular implant bed preparation that changed the way I drill today in the molar sites. He showed that drilling through the remaining roots, even on non-healthy roots, would allow the drills to follow a resistant pathway through the bone, which is less dense in order not to fall into the socket during our drill. So the roots would drive our drill. But there are some limitations, of course. CBCT is mandatory in order to measure the remaining bone. The remaining bone is necessary either in the septum for interradicular drilling, mesially distally, or at the buccal or lingual palatal sites in order to engage our implant. The macro design of our implant must be aggressive enough in order to achieve primary stability even when the remaining bone is insufficient or we have type 4 density. The absence of buccal wall because of infection or traumatic extraction may affect the outcomes and limit our protocol, being recommended to proceed with socket preservation and staging our approach. Soft tissue deficiency, either in buccal or lingual walls, may limit the surgical procedure by losing the references for proper implant position. And when we have no bone to place our implant, we must give up sometimes and do what we have to do, socket preservation. Let me show you two cases. The case number one, Matthias came because of his hopeless lower right molar that we had to extract. A CBCT was taken to ensure the presence of bone. The old and infiltrated crown was removed in this case, or the coronation of the crown is recommended. The drilling protocol of our implant company is performed starting with the Lindemann burr, as you can see in the left picture. An atraumatic extraction is performed and the implant placement must follow certain references such as the buccal wall for its proper position. Our implant should be placed 1 to 2 millimeters below the buccal plate when immediate implant placement is performed. And it's been proven that the buccal plate is located 1 to 2 millimeters below the lingual plate. That is why it's so important to have as a reference the buccal plate and not the lingual plate. The fraction 2 of PRGF mixed with synthetic bone, beta-2 calcium phosphate in this case, is packed into the sockets as well as the fraction 1, which we use to create membranes, autogenous membranes, and are placed on the top of it in order to compact the bone and avoid the particles loss. Crisscross sutures are used, and after 6 weeks of osseointegration, ISQ values are confirmed as well as soft tissue health. Here you can see the sequence of our protocol and the final result. What I like from this last picture is how we preserve the bone architecture compared to the adjacent teeth. At the end, we did not change the soft and hard tissue contour. This is my case number 2. This is my father in the middle, the gastric surgeon. My brother and I joined him in his last day of public service surgery, and I owe him my life. So he came to me and asked me to place some implants on him. We took a panoramic, a CBCT, and plantar surgery on his upper right molar under the same protocol. The only difference was that we were going to perform an atraumatic sinus lift at the time of extraction and implant placement. So we followed the protocol. We decoronated the molar, started the drilling, and following the paper from Markus Hurseler, we fractured the floor of the sinus atraumatically after the tooth extraction, taking the fraction 2 of our PRGF, placing it into the sinus just in case we tore the membrane accidentally. PRGF into the sinus is a safe and recommended procedure in case of tearing the membrane. We all know that. So the implant was placed into position, and the mix of PRGF fraction 2 with our bone graft was packed into the sockets, as you can see. Membranes fabricated out of the fraction 1 were placed on the top of the graft to keep the particles in place. And crisscross sutures were placed to finish the procedure. After 3 days, I received a call from my dad telling me, "I think I made a mess." After 2 days of surgery, he celebrated with his friends eating an Argentinian grill, drinking wine and smoking as a good Argentinian. And this is the way it looked after 6 days. We removed the sutures and an important adhesion was present. But I wanted to analyze this picture. I found that the membrane was gone. The bone exposer was present here, here, and here. But I also found good things that happened. Agglutination of my particles into the sockets. Adhesion of my particles. Graft integrity. And I saw no dry socket. Let me say that using growth factors, in this case, prevented me from having a dry socket, graft infection, and soft tissue necrosis. On a non-cooperative patient, as you could see. I must agree with Dr. Nito by saying that the use of growth factors helped me to succeed. And here in the final result, the most important thing, try to keep what we have, the original bone architecture, and no difference between our implants and our teeth. So starting from here and finishing here, I need to take a home message with this. And for me, the combination of the pre-extractive intraradicular implant preparation with the use of synthetic bone for implant placement after extraction is a predictable treatment option, especially with the addition of growth factors as an agglutinin matrix that enhances the healing process, keeps the integrity of a graft, promotes the reepithelialization of the tissues around the implant, and avoids infections derived from non-cooperative patients. So thank you very much, and I hope that you enjoyed, and I hope to see you soon. Bye-bye.